Welcome to our Yodo channel. Today what we wanted to discuss is wanted to open the topic for hospice discussion and talk about what hospice is. That's kind of a dirty word. People don't like hearing that word. But we're going to talk about it today in an informative, open format that maybe doesn't seem so threatening.
Exactly. We want to give you the information that you might need to help your loved ones or yourself through this journey.
So we'll kind of talk about it with you and with each other and kind of interview each other so you can hear us kind of do a little bit of role play even to discuss what hospice is. So what is hospice, Dr. T?
All right. Well, hospice is a service that allows patients that have a life-limiting illness to sign up for to have symptom management.
That sounds like a lot of words. Life-limiting illness. So I've heard hospice in the past, people say that's for somebody who's going to die.
Not necessarily. They do have a limit of 6 months or less.
If the disease is to the point where they think I'm only going to live 6 months, that's when they're going to sign me up for hospice.
Yes. And it's more based on quality of life and managing symptoms.
Okay. So they don't just start me on morphine and I die.
No.
Okay. Hospice is a service is what we're trying to inform you of. And as far as how do I get it, you have to qualify for it. Most insurances cover hospice care, but you have to have a life-limiting illness that if it follows the anticipated natural trajectory of the course, you have a high probability of end of life occurring within 6 months, then you qualify for hospice service.
Right.
And your insurance will cover it.
But how do you qualify, Dr. Baum?
Well, you have to have 2 physicians, usually one of the hospice physicians, and typically your I won't say your primary care, because it could be your primary care, it could be your specialist. They all talk with you and say, things are not going the way we like. We don't have cure available for you. If your disease follows the anticipated natural course, you've got a life expectancy of less than 6 months. So you're thinking, well, doctor, does that mean I can't have service anymore? No, you can still get care. You can still qualify for care, and you can still have care, and you can still go to your regular physician. You're not going to see all of your doctors because they've already told you that they don't have cure available, but you will see the hospice physicians. So hospice is a service. It's going to help manage symptoms that are limiting your quality of life.
Right. And it treats the whole mind, body, and spirit, the whole patient, not just their disease. And also treats the family. It helps, provide support in the home, which we will go into, that allows the family to have a little bit of peace.
So when we say treats mind, body, spirit, you're typically used to going to your physician and getting care for your body, but not necessarily mind and spirit. And so you're thinking, how is this service that's a healthcare service for people with serious illness, how is that going to address these other aspects? How does it address my mind? How does it address my spirit? And that's because there are so many disciplines involved with hospice service.
Right.
So once you qualify for the service, then you get it all, lock, stock, and barrel.
Right. So it's a comprehensive service. So you're not just going to a doctor. I mean,
actually they're coming to you.
They're coming to you, and there's a lot of people that come along with that.
And you can still leave your house. A lot of patients find that with home health, they have to be homebound. You do not have to be homebound with hospice service, but you do kind of want to have a schedule available. So if you're going to go out to the store, or you're going to go to the movies, or you're going to go get a pizza, you want to let those care providers know when you're not going to be home, so that they're not coming by the house while you're gone. Because there are quite a few on their discipline service that provide care to you. Dr. T, who are some of the providers on the discipline service for hospice?
Okay, so the physicians, they can either be board certified in hospice and palliative medicine, and some are not. So there is a difference in their level of expertise
and education.
There are also now ARNPs, which are advanced registered nurse practitioners. Then there is RNs and LPNs that come to your home. RNs are, and LPNs are nurses, different level of
So
nurses.
regular nursing staff will come by the house and they will evaluate the patient and, count your meds and do a skin evaluation and check your vital signs. And then they provide reports to the physician and to the nurse practitioner that are also caring for you.
Right. There's the licensed clinical social worker, which really helps not only with any type of things the family might need. For example, if they're looking for placement, like if they're home, they need more care in the home.
So the social worker is trained usually for counseling, so they can help with anxiety, they can help with depression, and not just for the patient, but they're also a resource for the family for those things. But the social worker also helps arrange with the nursing staff and the physician if durable medical equipment is needed in the home, if a lift is needed in the home, if a bed or oxygen, if those types of DME, durable medical equipment, if those types of items are needed in the home, they also help coordinate that.
Yeah, and they help with placement. So if your loved one needs to go to a skilled nursing facility or needs a higher level of care that cannot be provided in the home, they help the family make those decisions.
The social workers have helped. I'm sorry, I cut you off. The social workers have helped in the past when I have family members that need time off.
Yes.
FMLA paperwork. They've worked with the Red Cross to bring home military personnel if someone is not doing well and they would like to have a loved one that maybe is in active duty. Then they can help with all of those kind of social needs that the patient and families have.
Right. Each team also has a chaplain that's provided to them. And oftentimes people think, oh, I don't want a chaplain, that's too much religion. And they also will meet your religious needs because they treat all religions. So they're not specific to one denomination of Christianity, or if you're Muslim, they will meet you where you're at. They're very well versed. They learn about all the different religions. And what I like the most is they really help me as a physician understand the dying process from a religious perspective based on the patient's religion.
But they address it from a religious aspect if that's needed, or a spiritual aspect. So all religion is spiritual, but not all spirituality is religious. And they will address it from that larger global philosophical topic, looking down on things.
Right. And then I find for myself, one of the most important members of the team is the certified nursing assistant, because that is the person that goes to the home and helps the patient do their ADL care. And what I mean by ADL care, it's the bathing, the dressing. They will assist with meals if it's around mealtime to help the patient be fed, or help just set up the meal safely for them.
So that's the aid, and the aid is provided, and they typically will come between 2 and 4 times a week, build a really close bond with their aid.
Yeah, and I find that it's really, because of that bond and also the intimate care that they're providing, they're able to give a lot of feedback to the team of symptoms that need to be managed, because they're looking at the skin, and then they're also helping the patient with their bathing and their dressing, and sometimes symptoms pop up and they're able to communicate that to us.
So they'll help with that personal care that the patient needs. So the family is allowed to be the family, and they don't necessarily have to be the primary person to give them that intimate care.
Some patients have a lot of dietary changes that occur, so a dietitian is always available to the hospice interdisciplinary team. And then a lot of times patients and families do not realize, but PT and OT, physical therapy, occupational therapy, they play a significant role in the interdisciplinary team, because they're able to go to the patient's home, look at, for the occupational therapist, how to set up their room to be safe. And then physical therapy also will help with strength training.
They're going to come and try to help you learn how to safely transfer the patient. They're going to try to help you learn how to do range of motion with the patient, because many of the things that can be done, the family can learn how to do. and you don't have to have those therapists and those occupational therapists and speech therapy coming through your home, but doing that evaluation. They might not ever need therapy to come, but they might need therapy to come at different intervals because there's been a change in the patient status.
Right. And then also speech therapy. Speech therapy becomes important we were already talking about dietary changes. Well, a lot of times patients may have swallowing difficulties.
Or speaking difficulties.
And speaking difficulties if they've had a stroke or any other type of neurological symptomatology. So it's really good to have a speech therapist who's an expert, has a comfort level to really help not only the patient understand their disease progression, but as well also, more importantly, for the family to understand. Because sometimes families feel that patients are just giving up, throwing in the towel, and these disciplines really help you see the truth.
Right. Because we don't like to guilt patients. They are the ones who are suffering. They are the ones facing the illness. They are the ones that have been told their life expectancy is limited, and we want to be able to support them. So it is not about giving up. It's about making choices, and it's about choosing how you want the next few months to go. So if in 4 months or 6 months there is a priority for you, this team is going to help you reach those priorities.
Exactly. And then really what's really important, I really think the bereavement services are incredible because bereavement is offered to all the patients for 1 year after their passing to the family. Bereavement comes in early for children, oftentimes, to help the children prepare for the loss. I've worked with some bereavement specialists that made videos, music videos. They did life review. They left books for their children. Yeah. Just beautiful, beautiful things. And that is just so important because as we're living in that moment of dying, sometimes you forget how important it is to have that.
To leave a legacy.
And leave a legacy.
And the bereavement coordinator is specially trained in how to help families prepare and brace themselves for the change because it's going to affect everyone in the family. Everybody's position changes. Everybody's losing a particular person, but even though it's the same individual, it is a different person to each one of us in the family.
There's a different meaning for that person, for every member of the family, and we should not forget the children involved and the parents
and the relatives and the family and the friends. Sometimes, when I've cared for patients in a nursing home, they don't have a lot of other family members anymore, and their family has become the staff and the other residents in those facilities. And the bereavement coordinator helps with those people prepare for it. And if you think about people who live in a nursing home, it is very difficult because they lose someone. By the time you have enough changes occur in your life that you're living in a nursing home, your life expectancy may be 5 years or less. That's kind of common for life expectancy of somebody.
Scary.
Yeah, and they help address that, not just with the patient, but with all of those family members. And then the last one that I think is on our list for disciplines that work for hospice is the volunteers.
Oh, yes.
We have lots of volunteer positions. Some people want to work with a hospice because maybe of a loved one or because they feel called to that or they heard about it at the religious meeting that they would like to work with the hospice and help those people. But many of them don't ever actually interact with a patient. They work in the office because they just want to work, maybe 2, 3, 4 hours a week or maybe 1 or 2 days a week, and they want to provide extra help to
the staff.
Yeah, to the staff. So they may do filing, they may put flyers together.
Exactly. Some sew, there's these bereavement teddy bears a lot of hospices have where they use the patient's clothing to make teddy bears, so they do sewing.
So the volunteers are crucial and do so many good things for the hospice agency and provide things that go to the patients and go to the families.
Yeah.
Back to disciplines, there are many different disciplines that are involved with that hospice service. And you have access to all of them. Now, during the night or a weekend, if you need someone, you're going to contact the nurse because there is a nurse on call for a hospice patient 24 hours a day, 7 days a week, whether it's a holiday or not. So if, you're up at 2 o'clock in the morning and you go to the bathroom and you bump your elbow and it's bleeding, you don't have to go to the hospital to have it evaluated.
Right.
You could contact your hospice nurse and say, hey, I've got a rag on this and I bumped my elbow and it's bleeding and I would really like to have the nurse come out and check this. She can come out and do an assessment, and if she says, you just have a little abrasion there and I've got it cleaned and dressed, she'll call and report to the physician on call. She'll put a wound dressing on there, or she'll say, oh my goodness, this is really bad, more so than what I can fix with just putting a dressing on it. So I do think that you will need to go to the hospital and have it evaluated. But it's good for tonight. You can wait until 8 or 9 o'clock in the morning to go in. You don't have to go in at 3 a.m. and wait in the emergency department. You could maybe go to the doctor's office tomorrow and get it addressed.
And some hospices even provide mobile x-rays to come to your home, and it could be done in a more intimate manner and not being, very overwhelming to patients and family.
Many times by the time a patient feels like my illness has reached that point, I don't want to go back to the hospital again.
Right, and a lot of times, whatever needs to be done, can be done.
Sorry about the cat.
Can be done in the patient's home. See, this is real medicine.
This is real medicine.
Because you know what? Speaking of pets, we didn't talk about pet therapy.
We do. Many of that's another discipline that's offered by many hospices is the pet therapy, where they have licensed pets to deliver the pet therapy that will either go to somebody's home, and there are many requirements about the behavior of the pet, the bathing of the pet. So it's not something that they just bring a dog over.
No.
If they are going into a facility, there's a lot of requirements for those pets, and they have a test that they have to take. But that's another discipline that you have access to when you are eligible for hospice, and then you select and elect that hospice benefit.
Yeah, I think it's really important for us to emphasize that you select and elect the hospice benefit. It's not something that's put on you by physicians or clinicians. It is something that you have the right to, and you can select it.
Well, I was going to say the patient has to qualify. You have to have a life-limiting illness that if this illness follows its anticipated natural trajectory, the patient has a life expectancy, high probability of less than 6 months. And that's kind of vague, and the reason it's vague is because sometimes patients do better than anticipated. And study after study have shown that the earlier in the disease process patients accept that hospice care, the longer their life becomes and the higher the quality of life that's reported by the patient and the family. So we do want to put them on well before the last few days of life, but at that point there's really not much that can be done. We want to be able to provide that care and that improved quality of life, because wouldn't it be nice for you to still be able to be more active and to feel better? And it doesn't eliminate your ability to receive some care, certain kinds of care.
Exactly. There's a recertification process that occurs that is somewhat relatively new. It's been within our career that they now have this recertification process. So it starts out at the first 90 days, and then there's another benefit of 90, and then after that, that's a 60-day benefit. And what I mean by that is a physician or an ARNP has to go and assess the patient just to see that if their disease would progress in its normal disease trajectory, would it be 6 months or less? So they recertify that patient.
The patient doesn't have to do anything. It's all on the hospice organization. They send the physician or the nurse practitioner to the patient's house to do the evaluation, and do they still find this person at significant risk? And if the answer is yes, then they requalify. So it's a renewable benefit for them to continue to receive the in-home hospice care with all of those disciplines that we talked about. So you have to qualify, and then you have to say, I want that service.
And then who pays for it, Dr. Bone?
Insurances pay for it. Medicare primarily, because that's the Medicare population, is primarily the number one user, but also private insurances. Most all patients in the United States now have that hospice benefit on their insurance, and hospices, if they are paid by the insurance and federal government, so 99% of hospices must provide a certain amount of charity care. And what that means is if for some reason I fall in between the gaps, that I don't have insurance I don't have Medicare, and I don't have finances to pay for it, then that means that the hospice will pay for me on my behalf. That will not be billed to anyone, in myself or my family or an insurance company, but that will be part of their charity care.
Right, which is pretty impressive. And then we also want to discuss, like, where do you get hospice, right? Oftentimes, like when I first started, people thought hospice was a place
that you had to go there.
But really, hospice can be done in your home, wherever that home is. It can be in your private home, apartment, condo, if you lived in an assisted living facility, independent living facility, or a skilled nursing facility. Anywhere your home is, that's
where they go. So if you live in an RV, if you live in a tent, if you're in a nursing home, then hospice is going to come there, because it's a service, it's not a place. Mm-hmm. Now, hospice does have a couple of places that you can go to only under certain circumstances, and that has to do with the different levels of care. Hospice provides 4 separate levels of care. Some of those levels of care are in the home, and some of them are not. Mm-hmm. So for most patients, they have been told the bad, worrisome news that we don't have a cure available for you, and your disease has now reached that point where we think your life expectancy could be less than 6 months if this disease process follows the natural course. So they've heard that news, they hear about hospice, and they find out, I really don't have anything to lose by accepting that, because if I get better, I come off of hospice, or if I don't like it, I can discontinue the service. So I'm going to accept that hospice. Right now, I don't need a lot of service or a lot of help, because I'm fairly ambulatory and I'm in my own home. That level of service
is the routine home level of care. So it's a routine home level of care. And I would say, I don't know the exact percentage, but that's where you spend the majority of your time as a hospice patient.
About 60% of patients are at routine home care, where the hospice nurse comes by, the aide comes into your home, the nurse practitioner or the physician comes to your home. Sometimes when people first come on service, they'll tell me, my front door, it was like a revolving door.
Every day.
Because I had the chaplain came by, and the bereavement coordinator came by, and the LCSW came by, and the aide introduced herself, and the nurse came by. And then that second week, then the physician came through, and then the nurse practitioner came through, plus the nurse came back, and then the aide came back. So it just seems like there's a lot of people. At the beginning of care, there is a lot of people that will introduce themselves to you, and they all want to hear your story. They all want to learn about you.
Yeah, because as we said earlier, hospice is not about just treating the disease, it's treating the whole person. So I always warn patients when I'm meeting them in the hospital setting before admissions that, there's going to be a lot of people, just bear with us for the first 2 weeks. Everybody's trying to get to know you, and then it kind of, fades away and calms down, and you kind of pick it. So in addition to the routine home level of care, there's also an inpatient level of care. An inpatient level of care is usually at a freestanding inpatient unit. It can also be provided in a skilled nursing facility, but oftentimes hospices have a freestanding unit. Sometimes it can be done in a hospital setting if you're in a rural area that does not have a freestanding unit. And that's where you go for acute symptom management. And what I mean by that is, if you're in a lot of pain or shortness of breath, whatever your symptom is, and we cannot treat it at home, we transition people to an inpatient level of care to manage those symptoms. But it's not like going to the hospital. It's not like we have 7 or 8 specialists coming in. It's just the hospice team coming in, and our goal is to get those symptoms managed quickly so we can return you home.
So the IPU, or inpatient care unit, is when you have a symptom that's so severe that you can't tolerate being at home anymore. So let's pick 2 or 3 that I can think of right off the top of my head. Is pain is really bad, or my shortness of breath is severe, or my stomach is really giving me problems. I'm nauseated, I'm vomiting, and I need extra help, extra medication, and I cannot take it by mouth. So then the hospice would offer you to be cared for in their inpatient care unit, and you might need to be there for 2, 3, 4, 5 days for a short period of time while medications were changed and you were monitored very closely by their inpatient care staff. So in a lot of ways it is sort of like being at a hospital, but the rooms are much larger. They're usually much more friendly. You're usually allowed to have family members that are in the room with you. Sometimes family members stay overnight. And, you know, I know days before COVID that families would bring in, you know, whatever they needed. Sometimes it might be they would bring in a cooler, you know, so that they could have a meal themselves, or they didn't have to leave because they wanted to be present with their loved one that entire time. But while you're there in that inpatient care unit, they're going to be addressing those symptoms, and they're going to be changing your pain medications. You might have to start an IV medication until they can get you back to oral medications. You might need an injection. They're going to try to meet your needs by giving you those medications to get you back to home.
Yeah, now say that there's a point in your disease where you do have symptoms that need to be managed, and they can be managed at home. Instead of the inpatient level of care, the other level of care is a continuous care, or you know, people also call it crisis care. But basically, it's a level of a higher level of care where you have an LPN or a CNA at your bedside, and they are administering medications for pain, shortness of breath, any kind of GI upset, or sometimes just severe anxiety, because that's another symptom that we're managing towards the end of life. And we try to keep those patients in the home.
Sometimes patients don't want to leave their home. They feel like, I don't feel good. I want to have my things about me. I want to be in my home where I'm most comfortable. And so I want the nursing staff to come here. And so continuous care will provide that level of care until that symptom is managed. And then you can go back to, you know, having your family provide most of the care for you with the assistance of the hospice.
And the thing about continuous care is they're there to teach the family. So then when they are to step away and you go back to the routine level of care, then the family is empowered and knows how to administer the medications.
Survey after survey have told healthcare that patients want to be in their home. And I, you know, just think of the little girl from Kansas with her little red shoes. There's no place like home. There's no place like home. And when you don't feel good and you're already faced with what you think is a life-limiting illness, you've been told bad news, and you've had to, you know, go through all these treatments, and you're now understanding that cure is not possible. It's not that you're giving up, but you have chosen and elected that how you want this to play out is you want to be in your own home for this. And so we want to allow them to have that choice to be in their own home when they're not feeling well, and that's what continuous care would provide.
Right. And then the fourth level of care is the respite care.
Respite care is really more for the family than it really is kind of for the patient. So let's say I'm taking care of a loved one who really needs a lot of care and they can't get out of the home, but I really have some home improvements that I want to make. Maybe I want to expand a room, or I want to paint a room, or I need to remove a carpet, but it's going to be noisy and dusty, and I need that patient to, my
or
loved
attend
one.
a family wedding or a
I
graduation.
want to leave town. I need to, you know, I need to have a procedure done myself. I need to have maybe a knee procedure, a shoulder procedure, but for a period of about 5 days, I'm really not going to be able to provide that level of care for my loved one. Maybe I just need a rest. I just need some downtime. That's what respite care is for. And so the patient would be taken from the home, because they're not going to house sit for you while you go to your wedding, but they're going to remove the patient from the home and keep them in that inpatient care unit.
Right.
And the staff of the hospice will provide 24-hour care for the days that you are unavailable, and that's what the respite care is for.
Now that we've explained the 4 levels of care, who qualifies for hospice, what hospice is, we like to just, the common questions that are brought up, and the most common is do you have to have a DNR? A lot of times people think you have to be a do not resuscitate, and that's not true. Hospices will take you whether you are a full code and you want full resuscitation, or if you have a do not resuscitate.
The next question I think a lot of people, and we've addressed this a little bit, is a lot of people ask, who pays for this? Do I have to pay for that? And back to what we said earlier,
Nope.
insurance is going to pick that up. And if you don't have insurance because somehow you've fallen, in these areas now where there's a lot of cracks where people don't have coverage, the hospice will pick it up because of their charitable donations.
And when I elect hospice, does that mean no more treatment? No.
You still get treatment, and you still get treatment for multiple things. So let's say I'm being put on hospice for maybe a lung problem, and I get a cold, I can still get an antibiotic. I get a bladder infection, I can still get treated for that. I fall and break my shoulder or break my hip, I can still go have surgery for that. They will probably want to take me off of service during
to have
that
the
time
surgery,
period. To
and
have
then you
those
just
things
come
done.
back on when your surgery is completed.
But if I'm just taking an antibiotic for a respiratory illness or a bladder infection or a skin infection in my leg, I don't have to come off of service for that. The hospice providers and physicians will assess that. They'll decide what antibiotic is right for me. They will put me on the antibiotic, and they will care for me throughout that antibiotic treatment.
And I think it's really important, because we did not mention this earlier, is they will pay for it. The hospice provider pays for the medications that's related to the terminal illness, and that's determined by the pharmacist and the physician. Even medications that are super uber expensive that in the past you would say, oh no, they're not going to pay for it. That's decided with the medical director and the senior leadership of the hospice provider, because if we do feel that it's going to provide comfort, then it's obviously paid for. And then also it's important for us to, we've already discussed it, but just to summarize, that if you live longer than 6 months, it's
requalify.
okay. You
Yeah.
requalify, because we already went through the whole benefit
You're
period.
not stuck with it. If you don't like the service, you can terminate and end the service at any point in time.
Exactly. Or you can switch providers, because oftentimes
You're not
different
stuck with a
communities
particular provider.
have different providers.
So if you're living in Arkansas with your family member, and then you decide you're going to move to Texas to live with some friends, or somewhere else, they will coordinate. One hospice company will coordinate with another hospice company so that you can move that service. So you can start the service, stop the service. If you come on the service, go off the service. But it's a renewable benefit. 6 months doesn't mean that that's the end of it. So you're not stuck with it if either you don't like it, or you don't need it, or they say you don't need it because you've gotten so much better.
Right.
That does happen.
that does
sometimes.
happen. Some people do graduate, and that's a very joyful thing. It's nice to then see those people many years later. You know. The other thing is, I think it's really important for us to talk about some things that we hear that kind of makes our hair stand up on the back of our neck. As physicians that do hospice and palliative medicine, it is very easy for all of us, and as well the providers as well as the family, to judge or make accusations such as giving up.
Yeah.
You're not going to do anything anymore, Mom.
Yeah. Don't make them feel bad about saying, I'm ready to make some hard decisions, and I'm ready to choose how I want my life to end. That's not giving up. That's not the same thing.
I find giving up is when we don't make a choice, when we just allow things to happen and we're not in control of those of our destiny.
When we as healthcare people try to tell the family and the patient that what we are worried about is going to happen is you're going to be in crisis. We want to avoid that crisis, because it is not right ever or ever fair when you are in pain, short of breath, or at the end of life for somebody to say, do you want us to do everything? That makes it sound like if you say no, we're going to hold something back. And those are not choices. That's not what's to happen at all. That's wrong.
And that's why I think we said in the beginning, it's so important to try to get hospice early on in the disease process, to get to know your team, to build relationships, and then as you're progressing through the illness,
have them meet you where you are and have them provide that care, because it's all about hope. We want to always have hope. Hope is so important.
We never want to take away hope, and it's so important not to cause so much guilt, because guilt can also manifest in different ways for patients that are suffering, because ultimately the patient is the one that's suffering.
That's right. As the loved one, you may think that this is bothering you and upsetting you because you're seeing it happen and you don't feel like you can help, but you can help. Be supportive, be loving, be accepting, and tell them that, you know, you support whatever they decide. And they may be asking questions about how you feel because they're trying to feel out if they have that permission from you to change what they're hoping for. And the hope talk that I like to give people is hope changes, hope is dynamic, and hope should always be alive. Hope should be the last thing to die. So whatever you're hoping for, it varies and it goes through life. As we go on our journey, we need to have hope for the next thing. And so hope should be living and hope should change. And each family member needs to support the patient in what they're hoping for now.
I hope you enjoyed this talk, but we just like to end with life are the awkward moments between birth and death. Thank you so much for joining us.
Thank you very much for being here.
And we look forward to seeing you in the next video. Please shoot us a message, leave any comments. We'll be happy to talk about other things. And we hope you learned a lot about hospice today. And we'll see you on the next video.
Bye now.